I think it's a matter of awareness raising, of enabling people to understand what the issue is, and capacity building. And that's one of the huge challenges we have. Actually, Jeffrey Rose, the eponymous person I named with lecture, was with Jerry Stamler, who is in the United States, now 95, still active. One of the early proponents of capacity building, and they set up training courses, for example, and many of these organizations like the European Society of Cardiology and the American Heart Association are involved in training courses. And one of the courses that Jeffrey Rose and Jerry Stamler set up in the 1960s was training programs aimed at people in emerging economies, particularly to raise awareness of the issues of cardiovascular disease and the importance for research and policy in terms of prevention. And they've been enormously successful in that over the last 40 years or so. It's a small training course. They've trained about 1,800 people from 100 countries. Most of these people are leaders now, or have been, in cardiovascular disease prevention and treatment. And because they're around the world, they are able to carry on disseminating and training. So I think it's a never-ending sort of challenge to increase awareness and capacity building worldwide. Again, this comes back to Jeffrey Rose's approach, which is individual and population-based medicine. There's no doubt that there are genetic differences between different populations, even within, as homogeneous population. We've also, lots of studies have shown that there are people at high genetic risk and low genetic risk, and that they have different profiles in terms of risk factors. So I think when you're talking about individual treatment, it is possible to identify people who are more likely to benefit from a particular approach one or another. That's an individually tailored treatment. That's the whole challenge of personalized medicine. I think that's a completely different question when you're talking about best treatment for individuals, to asking the question, why does this population have so much disease? What are the major reasons that particular population groups have high rates of disease? And one of the most challenging things in UK, United Kingdom, which has a National Health Service, is despite that, we still have huge socioeconomic differences in cardiovascular disease risk and outcomes. And I think the same is seen in the United States. So one of the big challenges is to identify what the reasons are for these big socioeconomic disparities, which are not just in access to treatment, that's really critical, but also in understanding what the causes are and why some groups are more predisposed to disease than others. Well, understanding causes research is absolutely critical. Understanding what the reasons are for those, and then understanding where policy can have an impact. And one of the difficulties about population-based interventions is that they should apply the most impact comes from interventions that apply to the whole population, because it's the people, for example, who are most able to benefit, who are unable to make those conscious choices. So there is a lot of evidence, for example, that the population reduction in public smoking, through taxation, through indoor smoking, has had a huge impact in terms of reduction in cardiovascular health, but in the general population, but also for respiratory health and many other issues. But that has a lot of ethical and political challenges in terms of free choice and how far should you regulate individuals. It's the same in terms of taxation. A lot of debate now about taxation of particular foods. But there have been observational data, some natural experiments. For example, in Finland, there was a big public health concerted effort to try and reduce salt intake. And the way that you reduce it is because the major source of salt is in processed food. So one of the challenges was to persuade bread manufacturers, cheese manufacturers, to reduce the salt that they put into their food, and other approaches. But over the course of a few decades in Finland, this is by advocates in Finland who also had a strong public health approach, at the same time, it was observed that average blood pressure levels in Finland dropped, and stroke levels in Finland dropped by half. So whether there's a direct cause effect, we don't know, but public health approaches have the potential to have major impact on the population, but they are much, much more challenging in terms of ethics and politics. I think it's how we integrate new technology with public health approaches. The advent of personalized medicines, everybody can have their genes typed. My personal view is, actually, it's so complex that, for the individual, you can design treatments, but actually, the challenges for public health are going to be the same. It's identifying what are the major causes of ill health in the population. And Jeffrey Rose always said that the health of the individual cannot be disentangled from the health of the population that they come from as a whole. And the solution, as we have seen throughout the whole of human history, to health problems are not just medical, they're political and economic. And that is, I think, the big challenge, whether we have the appropriate social policies to improve health globally. I hope so. I mean, in the end, everyone wants to do good things. I mean, nobody wants their mortality to go up. I mean, if you ask any politician, and it's not just doctors. It's everyone in society. It's part of part of it is the general public. Because the general public have to be interested in having these changes. And part of the big successes in Finland was because the community themselves noticed that the men and young people were dying of heart disease, and they wanted to do something about it. And that was why some of these community programs were implemented. So I think everybody has the same interest at heart. Everybody wants better health for the whole population. The challenge is we all have to give up a little bit for it. And it's everyone understanding what we all collectively have to do together. The cardinal example is vaccination, because we know that vaccination prevents disease, but actually if you're looking at individual benefit, you as an individual don't get much benefit from it. The benefit of vaccination is because the whole population is resistant. And so ideally as an individual, what you would like is everybody else be vaccinated and you don't have any of the risks of vaccination, but that's not how public health works. So for all public health measures, every individual has to trade off a little bit for the collective benefit, and that's the hardest balance to make, I think, for public health.